I'd now like to introduce today's moderator, Tom Sullivan, Editor-in-Chief for Healthcare IT News, a HIMSS media publication.
Welcome and thanks everybody for attending today's Healthcare IT News webinar. It's all about revenue, a MIPS, QPP, and revenue cycle best practice plan sponsored by iHealth. As noted, I'm Tom Sullivan, Editor-in-Chief of Healthcare IT News, and it's my pleasure to serve as your moderator host today. We look forward to your questions and comments, which you can submit at any time by accessing the question box on your screen, and we will make every effort to answer all questions during the presentation's live Q&A. Our speaker today is Justin Barnes. Justin is a corporate board and public policy advisor. In addition, he is chairman emeritus of the HIMMS EHR Association, co-chair of the Accountable Care Community of Practice, and partner at iHealth, where he assists these organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X, and the voice of HIMMS Radio, so look and listen for him at HIMMS 17. Justin has formally addressed or testified before Congress, as well as the last two presidential administrations, on more than 20 occasions, and he has appeared in more than 1,200 journals, magazines, and broadcast media outlets. Justin, with that, I'll hand things over to you. Thank you for joining us today.
Thank you very much, Tom, and thank you very much for everybody joining us today. Taking the next hour or so to cover really the revenue aspects and impacts to your practice or your hospital, depending upon your strategy and your community. And before we dive in, we've had some recent announcements with a new administration, and I get a lot of questions around, well, what will, the appointee for Health and Human Services is Tom Price, and what do you think Tom's going to do? And Tom's actually been a good friend of mine for about 20 years now. He's from my state of Georgia, and I think bottom line is he's not going to make any dramatic changes regarding macro. I think you're going to see some changes coming around health insurance reform, and that's not our topic for today, but our topic really is focused around macro, MIPS, the quality payment program, and certainly the revenue components behind it, and the regulatory components behind it. But I think bottom line with Tom is he's a practicing physician. He has been for over 30 years. He's an orthopedic surgeon, and I think you're going to see him make the program even more streamlined and make reporting even more simple for care providers and eligible providers. So I think it's something you can look forward to. I don't believe you'll see those changes in 2017. But I believe you'll see some of those changes in 2018 and certainly for 2019. So I think it's very positive. The program does start January 1st, so less than 15 days or so from now. The quality payment program, and specifically the MIPS track and the ACO tracks, are going to start. So it's certainly something that you want to engage. You're here today, so you're taking a great first step. But I think we're in a good direction with how the program is going to be rolled out, and certainly even easier. Some of the reporting requirements may become 2018 and 2019. So look forward to that. Before we dive into some of the revenue components, and then also specifically MIPS and the QPP in general, I want to touch on really the changing healthcare landscape. And a lot of you are experiencing this today. You're living and breathing this on a daily basis in your community. But it's very important to look at your business even more so as a true small business, or in some cases a very large business. But approach it from a fundamental business aspect. But and you can say, well, that, of course, Justin, everybody does that. Well, they really, truly don't. So we want to make sure that we're looking at different service options, service lines, programs to participate in, partnerships, relationships, and certainly engaging consumerism. Those are all strategies that can bring additional revenue today, but also a lot of revenue for tomorrow, and then also setting you up strategically to how healthcare is evolving. And certainly very important to look at taking on or managing risk-based contracts. Certainly hospitals have been doing this for a long time, and practices have started to take this on a lot more, but still relatively few, less than 5 to 7% across the country, really are successfully managing risk-based contracts. And in some ways, MIPS moves you into this direction, but this is where the entire healthcare system is evolving. So just want to make sure that you're looking at that. But then also I see out there something called the pendulum effect. And what I mean by that is we know the community developments around practices being sold off to other practices or to health systems and hospitals, but I've also seen now, and I work with a lot of practices that are coming back out of that environment. So for various reasons, they've sold off over the last 4, 5, 6 years. But now there's a good swell of practices coming back out. So, and there's various reasons. Sometimes doctors are very entrepreneurial, and they go sell off and work for the hospital for a while and realize, you know what, I want to go do this on my own, or they get a little bit more confident on these new payment models and other programs that are out there, and they want to go tackle that. So I think it's important to understand that this swing is out there. These opportunities are available, and I think it's a positive stretch. I think it keeps a lot of checks and balances in all of our communities, and I enjoy engaging. Engaging it certainly when practices want to move off and set up an organization or some type of entity with other care providers. There's a lot of opportunity to be had there. But very important now in the business aspects is focusing on optimization, looking for efficiencies where you can get them, and also economies of scale, doing more with the same or even doing more with less. So we want to look out across your organization as well as your community and look for new revenue streams and profitability of current services or profitability of new services that might be offered. So, and I touch on this because when you look out over MIPS, the Quality Payment Program, and other programs available, you really see that by optimizing your revenue streams today, and certainly your revenue cycle, that's where really 80 to 90% of revenue enhancements will come today. Now, we certainly get you ready, and you want to start for MIPS and getting ready for MIPS and the Quality Payment Program starting in 2017, January 1st, but I think also it's very important to look at the different types of programs, you know, as it relates to your revenue cycle. So diving in directly into that, you want to look at specialty-specific types of programs, what programs are available to from your state, care delivery opportunities. And these are certainly opportunities that can drive revenue today. I'm going to dive into that here in a moment. But then also look at across different ways of conducting business with your organization, aligning processes, services, and innovations to ensure that patients can easily access scheduling, your appointments, and make sure patients, one important aspect here is that you can look at appointment scheduling to make sure that patients are being seen from within really the first 15 to 20 minutes. I think it's the study that I've seen recently, and Gallup came out with a great study, is when patients wait more than 20 to 25 minutes in the waiting room, there's a direct proportion to negative feelings to the care that they've received and the value of that appointment and that visit. So I think it's very important to look out to see how long your patients are waiting and to keep a grasp on that. Again, if you can keep it less than 15 to 20 minutes, that's perfectly fine. But again, when it goes over 20 minutes to 25 minutes, there's a direct correlation for patients to the satisfaction of their care and the value of their care. So I think something to look at and keep an eye on. Also, make sure that it's easy to make payments with your organization. Not just, obviously collecting copays, but not just, sending out a bill, but make sure bills are easy to read and also that easy to pay, such as online billing or online payments or anything like that. Also, very important, certainly as payments are being shifted over to patients more and more every day, that you actually collect that copay. It's very important at the time of the visit, not chasing that $25 or $35 or $50 after. It takes a lot more time, a lot more effort, and you're going to lose a good percentage of that opportunity. Of that copay. So whenever possible, try to collect that copay when a patient has presented themselves. Now moving over to really how to optimize your revenue cycle, and this is integrated into MIPS and the Quality Payment Program. I'm going to integrate that now for you. So looking at your revenue cycle, very important to audit provider workflow. You want to look for comprehensive documentation and notation, and make sure that you're looking for any under documentation and that you're getting paid for the service that you performed. Physicians regularly and providers very regularly, they downcode and they change codes, and they don't actually collect all the revenue that's really due to them. They're not capturing the assessments, there's the questionnaires that are occurring, there's evaluations, there's services, there's tests, there's screenings. All this is revenue that's available to you today, probably in the tune of 15 to 20% revenue increases if you actually capture all that as part of the encounter and the visit. But also all of that, those services and tests and assessments and questions all count towards your MIPS score. So and those are also very simple ways to integrate that into the flow of your electronic health record to ensure that you're capturing that at the right time during the encounter, and it's automatically captured. I'm a strong proponent of making the EHR and the health IT background and the health IT platform do the hard work for you on your side. You've all invested, you spent a lot of money on these systems, make the systems work for you. And also, so another best practice here is random chart audits. And again, this probably can't be done, it might be able to be done by somebody, a coding expert on your team, but it's not usually done by the person who does the coding every single day because they don't know what they're not doing. But the best practice that we recommend is have an expert, an outside person, an expert biller come in there, an expert coder, do it monthly or bi-monthly, look at about 10 charts per provider. And again, once a month or every 2 months. And really understand what, are there any missing charges, look for consultations, no notes, wrong provider noted, down coding, up coding, wrong missing 10 codes, missing modifiers. All of this, again, will increase your revenue if you're doing it accurately and appropriately, or fixing, or it also prevents rejections, denials, and audits. So it's a great opportunity just to keep your revenue flowing, get paid for the hard work that you're doing, but then also, again, this all counts towards your MIPS scores in a lot of ways. So, again, those are some of the best practices that I like to offer around the revenue cycle. And keep the future in mind. And I mentioned this before, but really make sure your EHR and your health IT is doing the hard work in the background. It can capture your quality measures, that you're currently doing for PQRS. It can capture that. It can capture it for MIPS, for other alternative payment models, or these advanced payment models. It can do it for other reporting programs and initiatives nationally as well as statewide or even regionally. So again, your EHR, making sure that the workflow, the documentation, your templates can capture the right information, capture the codes, and then automatically transmit it over into your MIPS scoring. And there's a lot of great systems out there that do that today, but it's one of the best practices that we like to implement with practices in hospitals across the country. Managing credentialing, monitoring PAR and non-PAR care providers. Very important here. There's one example where we were able to capture an extra $9 million a year for one of our health system customers because you can actually go out there and we play the game with the payers. What we found in this one example is that these payers were unrolling and taking the providers off the rolls every single month. And so we figured that out, and we would go re-credential the doctors every single month, and we still have to do that to this day. It's just whatever the payers do and the game that they want to play, you have to be able to play it with them. So it's very important. Again, monitoring PAR and non-PAR providers and playing that game with the payers, because again, their job is to keep as much money, and you guys know this better than I do, and it's ours to make sure that you get paid for all your hard work and what you're doing. And really optimizing collections through eligibility verifications and prior authorizations. Make sure, to the best of your ability, that you are doing any priors, certainly for a lot of the specialties, to make sure that the payer and your contract is going to pay for that visit and that encounter. Again, you can chase some of that down afterwards, but it gets a lot harder, a lot more manual work probably has to go into that process, and the odds of collecting that money drops fairly dramatically. So we just want to make sure patients are eligible and we're doing prior authorizations whenever possible. That will increase your revenue probably, again, by 10 to 15%. A lot of opportunities here to increase your revenue and your bottom line and your cash flow. And managing fee schedules. Best practice that we like to implement and we like to share is that we're matching fee schedules and payments and collections about every 6 to 12 months. In 30% of our encounters, we actually have to go back and re-bill or re-engage the payer to get the money back based on the fee, what we've already negotiated for the fee schedule. There's so much money left on the table there, and people don't go back and match again the payments and the collections to what they've already negotiated in their contracts. We recommend doing it every 6 to 12 months. It's a great opportunity. I mean, we actually guarantee you get in the middle of these types of strategies, 5 to 15% revenue increases and cash flow increases by implementing these best practices. So now moving over to some of the best practices also that will help you on the business side. Understand and manage your cost structure. Transparency, we're trying to push everybody to understand their costs. CMS is doing a better job of publishing what a lot of their costs are and their prices are, but also we're trying to get the private payers to do it as well. You've got to understand your cost structure. You really can't go at risk for contracts if you don't know what visits or encounters cost you. So that's going to be a constant now in healthcare from here to eternity of knowing exactly what things cost, unless you're in a full capitation type model, but most care providers are not. So, 92% of us operate outside of capitation or at least significant portions of capitation. So we've got to manage our costs. We've got to begin to take on more risk and understand your costs are critically important. Again, we want to streamline operations. We want to increase throughput. And we really want to focus on the cost of operations because they've gone up 50% over the last 10 years. But I promise you, your fee structures and your payments have not gone up 50%. We've been lucky to get them up a couple of percent. So again, we must mitigate costs of our operations across the board, hospitals and practices, clinics, and health systems alike. Understand your staffing models, because there's a lot of things that we can do on the revenue cycle side to free up capital, bring up additional capital, make sure you're successful with, say, MIPS and the quality payment program, but then also reallocate staff over to wellness, care coordination, population health, or other revenue-generating opportunities. That's where the entire healthcare system is shifting. So it's great to free up some of this money, free up some of these resources, and focus them on how healthcare and where healthcare is evolving. And here, it's just look to see where automation can help you. Where can the health IT that you've already purchased, the EHR, the billing systems, where can those help you, and how can those be tuned up to drive additional revenue, to drive more cash flow, to drive more profitability, and then also free up your resources to really focus on other opportunities to drive more revenue and more clinical and financial administrative best practices across your organization. So now here's some ideas for KPIs, key performance indicators that we like to go in there and discuss with practices. But you want to set them up based on the size of your organization, your specialty, or your hospital, or whatever your focuses are. We want to set them up. We want to drive down. You want to set them up on the revenue cycle side. We also want to set them up on the clinical side as well. Something that's near and dear to my heart is around revenue optimization. And that's certainly, I've covered a lot of those items and where we can drive more revenue, but also going after the denials and going after the root cause for denials. Only 60% of practices and health systems appeal their denials. That means 40% are leaving money on the table. We chase down 100%, and we believe everybody should chase down 100% of their denials. You want to appeal them. You got to be very tenacious. Again, that's money that's left on the table, and with 60% of practices and hospitals not chasing those appeals down, very, very important. And you want to look for, as I mentioned before, underpayment reviews. You want to go back and do a payer analysis every 6 to 12 months. I promise you will find money there, and it's money that's yours. You've already earned it. And obviously, during these audits, we want to look for incomplete and missing charges. And again, we'll try to do chart audits at least every 2 months. Very important, again, 5 to 10% revenue increase can be found there. Looking at efficiencies and throughput, we want to, again, manage patient wait times. We want to reduce those to 15 minutes or less. And once in a while, patient wait times can go longer because things happen, and that's perfectly understandable. It just can't be the norm. You don't want to start to affect your patient satisfaction. I think everybody heard the numbers that 5 to 15% of your payment and future revenue streams are going to be based on patient satisfaction. There's MIPS components in that. Obviously, a lot of hospitals are already working within this with the patient stat scores. So you just want to make sure that you understand this and we're working through that. You want to manage cancellation and no-shows. It's just, again, a lot of money there that can be lost or leaked if you're not staying on top of that. And there's a lot of very inexpensive solutions out there that can drive strong ROI, 20, 50 to 100 to 1 ROI. It's a great investment. It's just, again, it's bringing innovation in the middle of your practice or your health system. Coding turnaround time, you really want that to 24 to 48 hours. You want to make sure that you're getting those bills submitted and those claims submitted. And again, on the value-based care and how we're all shifting, we want to understand the true cost of a claim within your practice or your health system and just get to the bottom of what your costs are so you can begin to go at risk for your organization. So now I'm going to dive in now to the MIPS and specifically the QPP. But again, a lot of those revenue cycle components are going to drive 80% of revenue for your practice well outside of where MIPS is. But then also making sure that you're capturing the right coding, that'll drive your MIPS scoring as well. So now diving in, everybody knows that the final rule came out in October. We actually are just a few days away from ending the 60-day comment period. So I think this is great. They opened it up. They don't usually open up comment periods to final rules. So and I'm very bullish in the program. When you look at the different options available and the simplicity, if you've ever gone for PQRS or you've ever gone for meaningful use, you are very well suited to be successful with MIPS and the quality payment program, certainly for year one and probably for year two, and I'm understanding there. So bottom line is option one, as you see on your screen right now, and again, all this content is going to be shared with everybody. On the lower right of your screen, you can see the handout button. You can pull all these slides down. But then also at the end of this webinar, within the next 24 to 48 hours, we'll be sharing all this content out as well as a copy of this webinar. But again, option one is to stave off the 4% cut. So I want to start with there. So all you have to do is over a 90-day period, report one quality measure, one improvement activity, or either 4 or 5 ACI measures, advancing care information measures, to avoid a negative payment. So again, option one, to stave off that 4% cut that everybody's been reading about for years now, report one quality measure, one improvement activity, or 5 advancing care information activities, 4 or 5 depending upon your EHR certification. But it's not hard at all. It's easier. This first option to stave off the 4% cut is easier than any PQRS reporting period or any meaningful use you've ever done, and probably anything else you've ever done with CMS as a program. So it's a very low bar to stave off a 4% cut. And if everybody remembers, starting last year, you actually got a 0.5% increase. When MACA was passed and first came out and was rolled out in 2015, you actually got a 0.5% payment increase. You're going to get another payment increase in 2017. You got it for 2016. You're going to get it again for 2017 and again in 2018. So you're going to get actually 0.5% increases no matter what. But option one, you'll get your, you can stave off that 4% cut by doing one of those items, one quality measure, one improvement activity, or 4 or 5 advancing care information measures to avoid a negative payment adjustment. And that's over a 90-day period. Option two, again, is fairly simple, allows providers to submit measures, a mixture of measures and activities for a 90-day period or more. And this means they could start anytime past January 1st of 2017. And you can get a neutral, which you'll probably get an increase, but you can get a neutral. The way the law works and the regulation reads is you can get a neutral or a small positive payment adjustment. So I say option two really pushes you towards a 1, 2, or maybe even a 3% increase in your payments. So it's a great opportunity to bring additional money into your practice. So option one, very easy to avoid the 4% cut. Option two, you report a mixture of measures and activities for 90 days or more. You can get 1, 2, or 3% increase. So again, that's where probably most practices are going to fall. And I've already been setting up MIPS calculators and MIPS plans for practices and health systems across the country for the last month. And so I know most of them are going for options 1 and 2. But we also have a handful that are going up starting January 1st and are going to be ready for the full 365 days reporting. So you can start for option 3. Go as early January. I mean, you can even start as long as you're capturing the measures from January 1st, January 2nd on. You'll be in good shape. But go for the full 365-day reporting, and that's going to give you the best shot at getting a solid 3% or 4% increase. They can't guarantee 4% increase because there's formulas here, there's bell curves here, and there's going to be mixtures of different measures and activities. But if you're reporting and you have a good partner or you got a good team internally, you're going to have a solid shot at a 3% or 4% increase for 2017. And that obviously goes up starting in 2018. I'll cover that in a moment. And then option 4 is for the advanced APMs or the advanced alternative payment model. And that's for the Medicare Shared Savings Track 2, Track 3, CPC Plus, the oncology model. So, and there's several that qualify you under option 4. But most care providers are going to go for options 1, 2, and 3, and probably a majority they're going to go for options 1 and 2. And it's fun because I'm out there now on a daily basis setting that all up for a lot of practices and health systems. So now here on the slide in front of you, you're going to see the different payment adjustments. You've probably seen this slide, so I don't spend much time on it. This is very common. This has been shared out there for well over a year now. The only thing you need to understand is that these are all cumulative numbers. So if you choose to not participate in year 1, well, you'll be getting cumulatively your cut for year 2 will be 4%, but then if you don't participate in year 2, your cut's 9%. It's 4 plus 5. Then you add on another 7% cut if you've chosen to ignore the program in year 3. Well, that's 16%. Then another 9% is 25%. So you really don't want to ignore the program altogether. If you would like to debate that from the standpoint of, well, my son in the practice are retiring, the reason why I recommend going for the program is because the value of your practice is going to diminish very rapidly. So I think just strategically it would be very good to engage the program. But again, a lot of this content has been out there for a long time. Now diving into the different performance categories, you have quality, you have ACI, and you have improvement activities. Those are the three categories for 2017. I'm not going to touch the resource use cost because that'll begin in 2018. That was one of the changes that came out in the final rule that replaced the value-based modifier. But for 2017, we need to focus on these three categories: quality, ACI, and improvement activities. Quality will replace PQRS, and it will account for 60% of your total performance score. ACI, you need to do 4 or 5 measures, and I'll talk about that here in a moment, depending upon your EHR certification level. And that'll account for 25% of your performance score. And then for improvement activities, you'll need to do 2 or 4, depending upon the weight and depending upon the size of your practice, and that will account for 15% of your total score. So now, regarding the different categories for quality, and now a reminder, to stave off the 4% pending cut, you only need to do one of these categories. But if you want to go towards full credit, you can go, as in quality's sake, for this category, you want to go for all 6 quality measures. And if you do have an applicable outcome measure, you have to add one of those outcomes measures. This program is extremely specialty specific. So I think CMET did a very good job and listened to a lot of the feedback from all the different quality measurement organizations, NQF, and different forums and other key stakeholders to make sure that this program is extremely flexible. I was very impressed on the level of flexibility based on the size of your practice, where you practice medicine, the workflow of your practice, the specialty of your practice. So a great opportunity to go for all 6 measures. For example, in family practice, you have 55 quality measures to choose from, but you only need to choose 6 to go towards and move towards your full credit, or a 1, 2, or 3% increase, or 4% increase for that matter. Again, you'll need to do 1 to stave off that over a 90-day period to stave off that pending cut. So again, very simple for you to be successful with. On the ACI measures, depending upon your EHR certification year, if you have a 2015 certified EHR, that's the MIPS certified edition, you'll report 5 measures that will be required. And this really replaces meaningful use. But if you don't have the MIPS certified one, you can still use the 2014 certified edition, and you'll report 4 required measures, and that's under ACI. And then the new category is improvement activities, and that's 15% of your weight. And depending upon the size of your practice, if you have less than 15 participants in your practice or you're in a rural or a health professional shortage area, you only have to do 2 activities. You can do 1 heavy-weighted one or 2 medium-weighted ones. There's different formulas and mixtures. But again, you have 93 to choose from, and you only need to do 2 or 4, depending upon, again, the size of your practice or the different weights. So I'm going to show you these different weights because none of this program is scary. And as best practice, I like to tell people, if you've ever participated in PQRS, you've ever participated in meaningful use, or you've done any type of interoperability or sharing of information, data, you're well on your way to not only staving off any 4% cut or any cut, but you're well on your way to 1, 2, 3, or even a 4% increase. So it's a great opportunity, and I truly believe that engaging in this program will bring you more money in the future than you have access to today. And I'll talk about some of those models and calculations here in a moment. So now diving in, some of the takeaways I think very important. This program is pick your pace. It's not all or nothing with meaningful use. For example, if you don't participate, you don't satisfy all your measures, you don't get your incentive payment. Here it's not like that. You can do a mixture of measures. You can do a few measures. You can do a few more. You can do it over 90 days. You can do it over 180. You can do it for 96. You can do it for 210, whatever you want. It's a very flexible program. So pick your pace. You can start January 1st, 2017. You can start January 18th. You can start March 1st. You can start August 1st. I don't recommend waiting to the last 90 days because if anything goes wrong, then you could certainly get your 4% cut. And that's not a variable cut. So you don't want to wait I would not recommend waiting until September, October to start the program. I would start early in 2017, get some good partners to help you. This program is very easy to participate. It's very easy to navigate, but please don't wait. It's, as I mentioned, very flexible. You can choose which objectives or measures best fit your practice, your specialty, your workflow, or even where you practice medicine. And again, it's not all or nothing. You can get partial credit. You can go for bonuses. to easily avoid penalties and also increase payments. And again, most CMS programs don't have this inherent flexibility, so they certainly listened. And again, all this content will be shared with you, the slide deck, these handouts, and on the screen in the handout, you'll see a link that I had published about 6 weeks ago, a 4-point plan for success with macro MIPS and the QPP in Becker's Hospital Review. I touch on a lot of the financial successes because, again, like optimizing your revenue cycle is where my sweet spot. You can really bring in an additional 5, 15%, and these companies like mine, we make guarantees to that. But you want to optimize your revenue cycle. You want to stabilize your revenue cycle. That'll free up money for your practice, for your profitability, for your partners, but then also will free up money for to be able to focus on the quality payment program to bring in even more money. Clinical success, you want to make sure you have the documentation set up. You want to make sure that your population health and your care coordination is set up, that anything that needs to occur. There's certain opportunities, even outside of MIPS and the QPP, to make a lot of money and to participate in these new emerging programs. So I certainly think that's a great aspect to success. Technical success, make sure your health IT platform, in most cases, or at least I'd say most, in 70, 80, 90% of cases, practices and hospitals don't need to spend any more money on IT or technology. It's just about getting the right expertise or getting some great advice or having your current system tuned up to participate in the program. So there's a great opportunity there just to tune up your health IT infrastructure, make sure you get the right enhancements and the right functionality, get your EHR working hard for you, using the dashboards, make sure your dashboards are set up. Most of the leading EHRs all have these MIPS dashboards, and if they don't have them today, they're going to have them tomorrow. They're going to have them certainly ready for January. And then also make sure you're aligning your staff. You get the right expertise. They're trained. They're coached. They understand the evolution of healthcare and how these systems are transforming healthcare and how you do want to participate. I realize it can be a burden. It can be bothersome to people, but if you approach it with the right strategy, you get some of the right help and the right assistance if you need it, you can truly thrive. You can truly dominate and even grow your revenue streams dramatically. But make sure everybody's marching in the right direction. I think that's some of the help that I like to talk about. Now diving specifically, what does this mean financially for people? I'm going to go through a couple of examples, and I'll share some links where you can get even more calculators and examples. And if you, towards the end of this presentation, we are going to open up for questions and answers. If we don't have time to get to everybody's questions, you can certainly reach out to us. My team will spend the next 24 to 48 hours answering your questions because I think it's important to understand what MIPS means to you financially. And here's some estimates. We've created some own internal calculators working off of some of the data that CMS has shared. So for an average 4-doc family practice group, because all of this is specialty specific, so you want to look at your specialty, the size of your practice. But for an average 4-doc family practice group, it's about $9,500 your first year. And then cumulatively, it starts to grow. So if you look out in subsequent years, you'll see that it obviously starts to grow. I can't quite see it on my screen right now, but it's kind of funny. It's very small print. But you'll see how it continues to grow. And then I'll show you on my next slide right here how, again, these amounts grow. So you're up to almost $60,000 over 4 years for family practice. So again, a program that you do want to engage these programs. You don't want to ignore them because, again, these are cumulative. I think it's very important to see that and understand that. Most people didn't understand that there's a cumulative process and cumulative event. So now talking about what does this mean for specialty measures, again, there are 55 quality measures for family practice. And so a lot of flexibility and opportunity for you to pick the right measures that work for your workflow, for your community, and for how your practice wants to conduct medicine. And as I've gone through all these measures, and actually on our website, and if you ever want us to share, just ask us. We'll send you all the measures that are applicable to your specialty. We can show you all the family practice measures, or cardiology and gastro, and ENT, and orthopedics, and ophthalmology, and whatever your specialty is, internal medicine, pediatrics, OBGYN. We have all this built, and we can share them all with you. And not just the quality measures, but then also all your improvement activities, all the ACI measures. So because we like to show everybody holistically what this means. We don't have enough time today to go through all of that content for all of the specialties. I'm going to touch on a few key specialties. But again, and we'll be sharing all this content with you, and these handouts are available on the bottom of your screen. But I think it's important to see because probably 60% of the work that you already do today in the exam room, in during the encounter is going to make you successful with MIPS. It follows your workflow. It follows the work that you've already been doing. It follows what you've already been doing for PQRS or in your just a general line of practice and seeing patients. And if you've done meaningful use. So it integrates very, very well. And as you guys know, this program will eliminate over time PQRS reporting, meaningful use reporting, value-based modifier reporting, and all of that. So it's all integrated into one program, which I think is important to understand. So now I'm going to touch on cardiology and specifically what it means to practices. So again, for a 5-doctor group, 5-doctor cardiology group, about $44,000 year one. And then if you look cumulatively, you can see it's almost $200,000 or so as you begin to $173,000 over 4 years. So it really does grow, or no, sorry, $200,000, yeah, over 4 years. So it really starts to grow dramatically, $250,000. So it's a lot of money cumulatively for a practice when you start to look at these numbers and what they mean long term. And here's the cardiology measures. There's 20 to choose from as a cardiologist. Again, you only need to do one for to save up that 4% cut, but there's 20 to choose from. And again, if you can do up to 6, you get the quality category credit. So again, 6 gets you full credit. 1 saves off that 4% cut, but you have 20 to choose from. So again, it shows the flexibility, looking for the right measures. But I promise you, as I dive into these, and I have over the last several months, you really see that a lot of these measures are applicable to how you conduct medicine today as a cardiologist. Next specialty, orthopedics. We dive now into what this means for the average 6-doc ortho practice. $35,000 in year one. So you really can see how this can really add up for the average size orthopedic practice. And now cumulatively, if you start to look out, over $200,000 over 4 years cumulatively. So if you choose not to participate in the program, that could be that's the cut, and over $200,000 if you do participate in the program of additional revenue and income. So again, a great opportunity to participate in the program and garner the money that's needed for you. For orthopedics, specialty specific, 21 measures to choose from. So again, if you just submit one, you can save off that 4% cut, that looming cut that we all hear about. But if you report up to 6, 21 to choose from, but you report the 6 that are most applicable to you and your workflow, you can go towards your 4% increase for 2017. And again, all this content will be shared with you after this presentation. And again, we have even more specialties. Gastro, I'm going to touch on here real quickly. So $18,000 in year one for a standard 4-doc gastro group. So a great opportunity, again, for an incentive payment. And if you look out over 4 years, you're around $115,000 or so. So again, that's your pending cut if you don't participate in the program. And if you do participate in the program, that's the incentive. So again, a great opportunity to participate. And there are 16 measures to choose from for the quality category, part of the MIPS program. Again, only one to choose from if you want to save up your 4% cut, or you can do up to 6 to get your full credit under the quality category. But you have 16 to choose from. Again, looking for the measures that best fit your workflow. So now on the improvement activities, this is the one where you've got either 4 or 2, depending upon the weight, or depending upon if you practice in a group less than 15 eligible providers. And on your slide right now I'm actually show you 2 slides that will show you all 93 improvement activities. And the red 8 stands for the high-weighted ones. So you can do 2 high-weighted ones, or 4, or a mixture of 2 high-weighted ones, or 2 medium-weighted ones, and 1 high-weighted one. So again, a lot of flexibility here. So again, to qualify for your full incentive payment here, you need to do 1 to actually save up the 4% cut, or a mixture of 2 or 4, depending upon the weight or the size of your practice, to get your full incentive payment. So, and again, this is 15% of your weight. But again, it's a fairly simple program when you look at how the measures are right here, the activities are right here. You have 93 to pick from, and again, you only need to do 2 or 4 depending upon your practice and the and where you practice medicine, and or the weight of the activities. And again, all this content will be shared with you at the end of this presentation. But I want to take a second here so you guys can see it. So a lot of this you already, again, I like to say, a lot of this you're already doing as part of your normal workflow in your practice. So, and again, we'll be sharing all this with you at the end of this presentation. So on your screen now are the ACI measures. And again, all depends if you have a 2015 certified EHR, or I say a MIPS certified EHR, then you'll report 5 measures. And if you have a 2014, the non-MIPS certified one, then you will report 4 measures. But here's a sample of the different measures available to you. I'll leave it up here for just for a second. But again, a lot of this you've already done or you're doing today. So none of these there's no really gotchas in this program at all. So one of the things that I like to touch on, because we always talk about what CMS is doing, and CMS being obviously Medicare with the MIPS program, but on the Medicaid side, there's a lot of programs available. There's one system that we work a lot with. There's a district program, the Delivery System Reform Incentive Payment, that's available in 7 states today, and that's on the hospital side. And there's the health home model, that's also on the hospital side, but it does affect practices as well for sure. But also, there's a lot of state-based programs. And all states have different, there's the Blues plans have a lot of different PCMH type programs. As you see on the screen, there's oncology programs, state-based or carrier-based PCMH programs. But my point there is, and there's other quality reporting programs, there's a lot of money to be had in these different programs if you look out, and so in your community. So something that we do, we go proactively look to each state and look at what programs are available for practices and health systems. We bring those programs and we allow them to participate in those programs. And then we'll go in and set the health IT up and make sure all the registrations and attestations go right. We'll set up all the dashboards. But it's very important to realize we've got to start looking past fee-for-service. And PCMH is a great direction. Obviously, MIPS is going to move you in that direction heavily. Any type of shared savings or accountable care or value-based medicine models, or just risk-based contracts in general, or just quality reporting programs and quality reporting initiatives. Again, all states have these different initiatives at different levels. Some are not statewide. Some are just based in certain sectors of a city or a state or in a specific city. But some certainly are statewide, or primary care based, or specialty based. But again, I think it's important to begin looking at something that's one of the things that's been near and dear to my heart for the last 6-7 years now that I've been doing this practices, is going out to engage programs outside. I mean, obviously, outside of CMS. Obviously, I optimize all the programs that CMS offers and Medicaid offers in the state, but then also looking at what the commercial payers offer. So those are from the last 2 are from New York and Georgia. And here are 2 programs, just again, random examples. In Florida, there's a Blue Cross Blue Shield value-based VBC or value-based care program. And in Kentucky, there's a personal health care program, as well as the CPCI, the Comprehensive Primary Care Initiative. So again, and then probably a lot of you participate in the CPC Plus program that Medicare has rolled out. But again, a lot of great opportunities to get additional money at the state level and the federal level, and then certainly from the different carriers. So now we're doing a little bit of a recap before we turn it over to questions. What will it take to succeed financially? I think it's very important, as you guys have heard from me several times, to pay close attention to the bottom line. And when I mean that, when I say that, what I mean is when you look out at what we can do to generate additional revenue, and again, I live and breathe this every single day. I go out and help practices, increase their revenue 5, 10, 15, 20%. And by optimizing their revenue cycle today, maybe looking at a couple quality reporting programs, but 85% of that new revenue comes from just optimizing their business operation today. And then we want to set them up for what MIPS and the QPP. You're going to get bigger allotments of money, but starting 2017, 2018, 2019, when those programs all start to kick in on the value-based side. But you want to make sure that you get the money that you already have earned today. So optimize your revenue cycle today, and then switch over to making sure that you're getting all those value-based medicine, those quality-based and outcomes-based reporting programs. So operationalize your efficiency today internally. Look at certainly your financial health, your clinical health. Optimize coding, making sure you're doing comprehensive coding. You're capturing the codes at the right time as part of the encounter. You're sending out clean claims. I think we're at 99.2% 92% clean claim rate. That's very important. Get that claim out accurately the first time. You don't want to, have to resubmit and then you delay your cash flow, or you just handle a lot more denials and rejections that way as well. Denial management is very important, but not just appealing, but you want to get to the root cause. There's a lot of analytics and strategies that we can deploy to look at why are we getting denied. Let's get to the root cause of the denials and mitigate those and eliminate those. So then we're only chasing down new denials and new issues, because we can really increase cash flow by doing that, not just increase revenue, but also really improving your cash flow from here moving forward. So it's very, very important. Again, be tenacious, chase down 100% of denials, but then also get to the root cause so you don't have as many denials moving forward. Eligibility and authorization management, eligibility verification. Make sure that you do that as much as you can on the front end. I would say 90 to 95% of patients should have eligibility verified or authorizations before any encounters or certainly any patient visits, because you want to make sure, again, you're going to get paid for that visit and you're going to ensure what you're going to get paid for that visit. Pay very, very close to payer contracts. Audit payer contracts every 6 to 12 months. Look for variance rates and make sure, again, that you go back and audit. 30% of practices leave money on the table. I think it's a lot of money to have left out there. And 30% of claims leave money on the table, sorry. And then make sure you have KPIs set up on the revenue cycle side. Make sure that you're hitting your, the days in AR, and make sure that, your cash where it needs to be. Your cash is growing. Your cash flow is there. There's so many components and KPIs, your denials, and make sure that those are being, appealed 100% of the time. We want to set up these KPIs, and we want to look at them through dashboards. It'll help you significantly to be able to simply know exactly where you are. What will it take to succeed clinically? I've gone through this, but again, a focus on making sure you're optimizing the revenue cycle side. Make sure you have that capital, and anything that you need to invest on the quality side or setting this all up is there, and it certainly can be. You want to integrate the data from financial and clinical sources. And again, as I've mentioned several times, make sure that we've customized that EHR, that it's doing the hard work for you. We've customized that EHR platform to capture the data, offer you the dashboards, even if we even use a technology platform, an innovation platform, where we can even look across a community of disparate databases and pull in all this financial data from 3 or 5 or 10 different billing systems and give you one consolidated view. We also can do that on the clinical side to make sure that these practices are hitting their whatever dashboards that they need to hit, whether it's for MIPS or the quality payment program or any type of other quality reporting initiatives or just care coordination in general. So I think it's very important to make sure that you've got this integrated. You can do that sometimes within your own systems, which is terrific. We always want to leverage existing systems where we can. But if you don't have the inherent technology or infrastructure, we can certainly layer on an innovation layer. I think that's important. And you want to make sure people can do that for you and don't charge you for it in most cases. Also, there's one thing near and dear to my heart is make sure people go at risk with you. They don't charge you upfront fees to do business with you. I believe in the at-risk model, certainly where we are in healthcare today. Everybody's asking you to go at risk. Ask your partners to go at risk. If someone's trying to talk to you about a service, well, force them to go at risk. We go at risk with 100% of our customers and our prospects and our clients. I think it's very important to make sure your partner, your people that you go to business with and do business with are willing to go at risk with you. I think that says a lot about how confident they are and their abilities if they are willing to go at risk with you. Implement best practices. I'm a best practice hound. I think it's very important that you set that up no matter what you're doing. And again, it goes back to even simple ways to conduct business with your organization and that you're setting up to do business with you, whether it's easy to schedule an appointment with you. The number one issue with a lot of health systems and even practices is patients can't get through to the practice. That's not good. Those people are trying to see you. You want to make sure that they can schedule appointments. They can be seen on a timely basis. They're seen on a timely basis. So not only to make an appointment on a timely basis and be seen being, 1 day, 2 day, or 5 day, or 10 day, whatever that variance needs to be, but also when they come in, they're being seen within 15, 20 minutes of their appointment time. Very important. But there's a lot of best practices there. Best practices on the revenue cycle. We've covered a lot of that. Best practices as you're engaging MIPS and any quality payment program, but also have an overall strategy of what do you want to do strategically outside of maybe MIPS. Maybe MIPS is what you want to tackle in 2017, and as we successfully do that, maybe you look out to what other quality payment programs do you want to participate in starting in 2018? Just make sure you're setting yourself strategically up to optimize your opportunity. Set up scorecards, monthly or quarterly, to make sure that you're hitting all the KPIs that you want to do. You want to measure your partners, you want to measure yourself, you want to measure your team. If you don't measure it, you can't lead to it, and you probably aren't going to receive the results that you want. But if you can measure it, you do have these scorecards. We force scorecards in it with everything just because we want to make sure that everybody sees the success that we're achieving and everybody's happy. It's a great way to look at your success and for everybody to be, joyful together and see and achieve success and see success together as a team. Care coordination across the continuum of care. You're going to hear more about care coordination. You're going to hear about collaborating on patient care. Obviously, the PCMH, the patient-centered medical home, that type of a model is very important. That's now rolled out to a lot of specialties, and specialties are being brought in to these types of care models. And you're going to be paid on it because we're going to have to optimize outcomes through care coordination and overall population health, and that's where payments are going to be following suit. Certainly, 2017 with MIPS is fairly easy to be successful with it. You probably need a little bit of help maybe to get your full 3 or 4% increase. But come 2018 and 2019, that's where the outcomes measures are really going to come into play, and your payments are going to be increased dramatically, and where the weights are going to be. It's going to how are we seeing success? Are our patients getting healthier? Are we seeing improvements in care? Are we seeing improvements in how care is being delivered? Are we seeing patient satisfaction grow? That's where 2018 and 2019 will come in heavily. So you want to make sure you're really well optimized in 2017. It's another reason why I don't recommend waiting to the very end, because it's not just about getting, staving off a 4% cut. It's making sure that you're set up strategically to be optimized for when 2018 and 2019 hit in 2020, then your systems are ready to really crank and optimize your capabilities. Because again, so much money, a majority of money is going to be focused on and weighted towards outcomes and quality-based payments rather than fee-for-service type of model, certainly in 4 to 5 years from now. But you're going to see big changes in 2018 and 2019. I do promise you that around this. And I'm a big proponent of patient engagement, patient education, and empowering your patients. Patients are very smart in a lot of cases. They want to engage their healthcare. They know a lot about their healthcare. And probably in most cases, they know more about their medications and their healthcare than the providers do, because they're handling their conditions. And so we want to treat them with that respect and engage them. Give them portals to use. You can always approve the data and information that they put in and validate it, but make sure patients are pulling their end of the weight. And in a lot of cases, they want to. They're using technology in every part of their life except healthcare in some regards. And a lot of health systems are using technology. A lot of practices are using technology, and that's terrific. Please continue that. Please continue to innovate there. Move out more innovation. The more integrated, the more educated, the more engaged, the more empowered your patient is, and the patient devices and strategies that you deploy are, the more successful and more healthy or healthier your patients are going to become, and probably more satisfied they're going to become. And that means all more money for you. It also means a healthier population out there across the country. So one of my favorite quotes in the mantra that I live by, and I personally believe, and I mentioned this before, that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. I wholeheartedly believe that. I've lived by this for many, many years. I've been doing this for 20 years now, and I know there's a lot of success to be had. There's a lot more revenue to be had. But if you choose not to navigate these new payment and care delivery models, then you probably won't. You will see cuts. Your world's going to change dramatically. But if you do choose to engage them, you get the right expertise around you, you get the right teams around you, the right people, the right employees, and the right strategies, you will thrive. I promise it, and I guarantee it in most cases. So I like to leave you, before we open up for Q&A, I like to leave you with some great links. CMS is a fantastic website, qpp.cms.gov. They will walk you through all the different measures for your specialty, the quality measures, the process measures, the ACI measures, the improvement activities. Everything can be found out there. Again, if you want my team, I can serve it up for you just for your specialty, send it to you in a spreadsheet, Excel spreadsheet, or you can go out there and look at what CMS has. We also offer a lot of best practices behind the scenes. They just give you the granular what the regulation says. Our website is there, ihealthinnovations.com. We have a lot of content. I've spoken 20 times now over the last 6 weeks on this topic. So a lot of specialty-specific webinars out there. Certainly check those out. And then CMS has a great website, innovation.cms.gov. It doesn't talk about all the different programs available, but it does talk about what's happening, a lot of the programs in your backyard. So go out there and check that out. I do like what the Innovation Center is doing and what they've been able to accomplish over the last 6 years. So with that, Tom, I'll turn it back over to you for any quick questions.
Thanks, Justin. You're a master of packing several hours, if not days, of information into a single webinar. And still leaving time for a couple of questions. We have a lot of questions. We won't have time to get to them all, but I'll try to sneak in at least 2 or 3 here. For starters, and you touched on this in closing, but during the webinar you addressed the benefits of participating in these programs. Let's turn that around and ask, what should practices that choose not to take part in MIPS or the QPP expect?
Yeah, and that's a great question, and that's a good question kind of for everybody too, just because strategically, if you don't engage these programs, yes, you're going to get a 4% cut, and that's not variable. You're going to get a 4% cut in your 2019 reimbursement rates. So I think it's good to understand that you will get that. However, it also means that you're going to be pulled off of roles. You're going to be from insurance carriers. You're going to be pulled off of referral streams. It's going to affect you a lot of other ways. It's not just what CMS is doing, but strategically. There's a website called Medicare Physician Compare. I recommend everybody goes out there and see what CMS publishes on your practice today and you as a physician today. But all of your MIPS scores will be published up there as well. So, and carriers can all see that. They'll go out there and other providers. And if you're not participating in these programs and you've totally chosen to ignore them, you're going to be pulled off of roles. You're going to be pulled off of referral streams. I promise you it's going to affect you negatively. So that's why I try to make this very simple. I try to have a very upbeat message. It's easy to be successful with MIPS and the quality payment program. Thank you, Tom. Great question.
Now, taking all that you just said in that great answer into account here, and as a baseline, how does a practice know whether or not it needs to participate in a quality payment program?
Yeah, great question. So if you're a physician, if you're a PA, MP, or nurse specialist, or a certified RN and anesthetist who bills more than $30,000 in Medicare and provide care for more than or provide care for more than 100 patients a year, you are eligible for the quality payment program. So you bill more than $30,000 in Medicare or provide care for more than 100 Medicare patients a year, you're eligible for the program. So, I mean, I think it's about 70% of Medicare providers are eligible. I think that's where the ballpark number, 68, 70%, somewhere in there. So, great question.
So, and I'll ask this as a last question since we are at the top of the hour, but given that 68 to 70% are eligible, we've got MACRA, MIPS, QPP, where do they start?
Yeah, I think there's a couple of great areas to start. I think checking out the QPP.cms.gov website is a great place to start. You can reach out to me personally. I can give you a glide path, some real simple outline plans. No cost at all. It's just very simple ways to participate in the program. There's only a couple reasons why you would need to register, and I can go through those. If anybody has any questions, I know we'll have a bunch of questions that we can't get to, but I have made the commitment that any questions that you type into the question pane now, me and my team, we will hop on over the next 24 to 48 hours, and we'll get all the answers back to you. It might take us a little bit longer if we have to work in partnership with CMS because some of the questions are fairly granular and are not covered in the final rule. So I work in partnership with CMS on a daily basis, but to get you any answers as well. So we'll do our very best. But I think CMS is a great place to start. My email address is on the screen right now, and my company will help you as well, Tom. Thank you. Great question.
Justin, thanks again for taking the time to share your expertise. I certainly learned a considerable amount about evolving payment models, and I believe our audience members did as well. To those audience members, thank you for joining us today, and please be sure to complete the evaluation on your screen and share any thoughts with us. As you mentioned, Justin, we didn't have time to get to everyone's questions. Just a reminder that Justin and his team will follow up directly with attendees to answer those questions during the next 24 to 48 hours. Finally, today's session will be available on demand until March 14th, 2017. Thanks again, everyone.